Hello and welcome to the module on cutaneous malignancies, where we will discuss melanoma with the non-melanoma skin cancers being covered in the associated handout. My name is Dr. Christine Walko. I am an associate member in the Department of Individualized Cancer Management and the team lead for precision medicine at the Moffitt Cancer Center in Tampa, Florida. This presentation is part of the ASHP, ACCP, BCOP Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive, with questions posed to you at several points. I will pause to allow you time to consider how you would answer each question. You may wish to write down your answer and the correct response in your handout. Any notable disclosures are listed here, and notably, I have no relevant disclosures to state. The learning objectives are listed here. Our discussion will really be focusing on the medical management of melanoma. Notably, there are now uveal melanoma guidelines in NCCN that are not included in this discussion. In addition to the topics that we will be discussing today, the handout will cover additional topics, including non-melanoma skin cancers, including basal cell, squamous cell, and Merkel cell carcinomas. I would like to note that the ASCO guidelines focused on the management, the systemic therapy for managing melanoma did come out after these slides were finalized. In general, they do largely agree with the NCCN guidelines, but you may notice some differences in the discussion. Before we discuss treatment, it is important to cover prevention. The best way to avoid getting skin cancer is to limit direct exposure to the sun. This includes limiting exposure between 10 a.m. and 4 p.m. when the sun is most direct, wearing hats and other clothing that cover as much of the arms, the legs, and the torso as possible, and using UV protection, including clothing that is now available with a protection factor of 15 to 50. Avoiding tanning beds and sun lamps is always recommended. And wearing sunscreen with an SPF of at least 15. I will note that the SPF of at least 15 is a recommendation by the CDC. The American Cancer Society actually recommends an SPF of at least 30. SPF indicates the level of protection against UVB rays, which are the main cause of sunburns. Broad spectrum sunscreen has been tested and shown to prevent exposure to both UVB and UVA rays. A sunscreen that has an SPF of 15 filters out about 93% of UVB rays. An SPF of 30 filters out about 97, and an SPF of 50 filters out about 98. So as you increase the SPF of the sunscreen, the higher you go, the smaller the difference. But again, if you have a question, the CDC recommendation is an SPF of at least 15 because this is what the studies utilized. It is recommended to use about 1 ounce of sunscreen, so that's about a shot glass or a palmful, with reapplication every 2 hours, more frequently if you're getting wet, so after swimming or sweating. So this brings us to our first case. Our patient AB is a 52-year-old man with newly diagnosed stage 3B melanoma involving his right upper back. He underwent a complete wide resection, and next-generation sequencing, or NGS, confirmed the presence of a BRAF V600E mutation. No satellite or in-transit lesions were found. Our patient AB wishes to pursue adjuvant therapy. So which of the following is the most appropriate adjuvant treatment for AB at this time? The combination of encorafenib and binimetinib, interferon alpha, Dabrafenib and Trametinib, or Nivolumab and Ipilimumab. So the most appropriate option is Dabrafenib and Trametinib. Encorafenib and binimetinib are also a BRAF MEK combination, but That combination is not currently approved in the adjuvant setting. It is only approved in the metastatic setting. Interferon alpha is no longer recommended for the treatment of adjuvant melanoma outside of some clinical trials which are still considering it in combination with some other therapies. Anyone who has used interferon alpha for their patients in the past is probably not too upset about this change. Dabrafenib and Trametinib, as I said, is the correct and approved option. Nivolumab is approved as a single agent in the adjuvant setting. However, the combination is restricted or is currently only approved in the metastatic setting. The rest of our discussion will focus heavily on systemic therapy options, though I do want to briefly highlight localized options like surgery and radiation, which do have a role in managing some patients with melanoma. For surgery, it is the best way to cure melanoma. We want to try to cut it out and cut all of it out to have very clear margins on either side. Surgery can be utilized in all stages of melanoma and is especially essential as a single agent modality in the localized and regional settings. For radiation, we use it less in melanoma than in many other types of solid tumors, but it can be also utilized as a primary or adjuvant treatment for some patients, and it can also be used for palliation in more advanced disease. So this slide provides an overview of the most common treatment options that we currently use to treat melanoma. For those of you who have treated melanoma for years, this is a very, very welcome slide to see. We used to use much harsher immunotherapies like interferon, interleukin, which still do have some role in the management of melanoma, but really the immune checkpoint inhibitors like Pembrolizumab, Nivolumab, and the combination of Nivolumab with Ipilimumab represent the cornerstone of immune checkpoint therapy for these patients. And really, that's because of the superior efficacy that they provide over our older therapies and a much more manageable toxicity profile in many cases. We also have our BRAF and MEK inhibitor combinations. These include Vemurafenib and Cobimetinib with a more recent addition of consideration of with or without atezolizumab, the combination of Dabrafenib and Trametinib, or Encorafenib and Binimetinib. As a reminder, if you're not used to utilizing these agents, you can kind of tell by the name what target they inhibit. Vemurafenib, Dabrafenib, and Encorafenib all have a RAF in them, and they are all BRAF inhibitors. And each one of them is paired with their respective MEK inhibitor. So, and Cobimetinib, Trametinib, and Binimetinib all have a ME in their name. So that's how you differentiate the MEK inhibitor from the BRAF inhibitor. We also have an intralesional injection, Talimogene Laherparepvec, which is T-VEC, and we'll also talk about where that drug has a role in therapy. And this is just where I will personally add how much my own passion for melanoma really drives from seeing this disease go from a time when we really did not have great therapies and we were using drugs like temozolomide, which you're not even going to see on this list except for the in the much later line, less preferred settings. And these new therapies have just really revolutionized how we're able to treat melanoma for our patients and to have many of the patients that are still alive even with advanced disease. So we'll now start talking about systemic therapy options for melanoma. You'll notice that we do start with resected stage 3 disease. Adjuvant therapy is not recommended outside of a clinical trial for stage 1 and stage 2 disease. These patients are typically managed with local therapy, specifically surgical resection. Additionally, observation, which is last on this list, is the preferred modality for patients with low risk of recurrent disease. So these do include stage 3A patients that have less than 1 millimeter of nodal involvement. The majority of adjuvant therapy trials did include only stage 3A patients that were considered higher risk. And one notable difference is that these trials typically utilize the AJCC 7th edition staging, where stage 3A patients by that classification were actually higher risk than the new 8th edition staging. So both Nivolumab and Pembrolizumab are both preferred options. They're both category 1 for patients with resected stage 3 disease with either a clinically positive lymph node or positive sentinel lymph node. The difference is that Nivolumab is approved for AJCC 7th edition stage 3B and C disease, whereas Pembrolizumab is also approved for stage 3A disease. Both of these options are category 2A for other patients with stage 3 sentinel lymph node positive disease. The combination of the BRAF and MEK inhibitor, Dabrafenib and Trametinib, is preferred for patients with a BRAF V600 activating mutation. It is a category 1 for patients, again, with resected stage 3 disease with either clinically positive lymph nodes or a positive sentinel lymph node and an AJCC 7th edition stage 3A with a sentinel lymph node metastasis of greater than 1 millimeter or stage 3B or C. So again, this 3B or C, you can use any one of these three options if the patient is BRAF V600E or K positive, or for stage 3B or C BRAF negative, you would utilize Nivolumab or Pembrolizumab. It is notable that other BRAF MEK inhibitors are not currently FDA approved in the adjuvant setting, so your Vemurafenib and Cobimetinib or Encorafenib and Binimetinib. However, they may be considered in the context of unacceptable toxicity to Dabrafenib and Trametinib. So the approval of Nivolumab in the adjuvant setting was based on the CheckMate 238 trial, where Nivolumab was compared with Ipilimumab in 906 patients with completely resected stage 3B, 3C, or stage 4 melanoma. You can see the dosing that was used there was Nivolumab 3 milligrams per kilogram every 2 weeks for up to a year, and the Ipilimumab dosing was actually the higher dosing, the 10 milligram per kilogram, every 3 weeks for 4 doses, and then it was given every 12 weeks for up to 1 year. So both patients got up to 1 year of therapy. The primary endpoint was 12-month median relapse-free survival, which was superior in the Nivolumab arm, and this was statistically significant. This is the reason why Nivolumab now is a preferred category 1 option in the adjuvant setting, and we no longer see Ipilimumab 10 milligrams per kilogram as a preferred option in this setting. Additionally, the adverse effects again favored the single-agent Nivolumab, with 14% of patients in the Nivolumab arm having a grade 3 or 4 toxicity, and almost 46% of patients having a grade 3 or 4 toxicity in the Ipilimumab arm. So we have superior efficacy and lower toxicity, supporting why Nivolumab has this indication. So the KEYNOTE 54 study assessed Pembrolizumab in the adjuvant setting. So unlike Nivolumab, which was compared with the Ipilimumab 10 milligrams per kilogram, Pembrolizumab was compared with placebo in the adjuvant setting. So in about a little over 1,000 patients with completely resected stage 3 disease. Pembrolizumab flat dosing was utilized, and again, similar to the Nivolumab study, it was given for up to 1 year. The primary endpoint of 3-year relapse-free survival favored Pembrolizumab. Additionally, adverse effects were seen in 14.7% of the Pembrolizumab patients. It is notable that overall survival from this study is not yet available. But based on the prior study and this study, Pembrolizumab and Nivolumab are both options for stage 3B and C completely resected patients. For patients with stage 3 disease who have satellite or in-transit lesions, which are defined as either a satellite lesion being less than 2 centimeters away from the primary tumor or in-transit lesions that are greater than 2 centimeters away from the primary tumor, the NCCN Category 1 recommendation is for Talimogene Laherparepvec, or T-VEC. There are additional Category 2B options that are discussed in more detail for this patient population in the handout. So T-VEC is actually a herpes simplex virus, HSV, type 1 derived oncolytic virus. It was designed to selectively replicate in tumor cells and then cause tumor lysis. And they did this by modifying several aspects of it, including by decreasing the pathogenicity, increasing the tumor selective replication, and also engineering it to express granulocyte macrophage colony stimulating factor, or GM-CSF, to increase the cancer immune recognition. T-VEC was initially compared in a phase 3 trial to GM-CSF in about 436 patients with stage 3B to 4 injectable melanomocytes that were not amenable to surgical resection. So one thing that is unique about T-VEC is that it is injected intralesionally, and the dosing is actually based on the size of the lesion. This is discussed more in the handout. This was compared with subcutaneous GM-CSF. And the primary endpoint was durable response rate. The results ultimately showed a statistically significant improvement in durable response rate. However, the overall survival was very, very close to reaching statistical significance with a p-value of 0.0494, but did not quite get there. It was notable that responses were higher in patients with who previously were untreated, and the greatest benefit was seen in stage 3B and 3C patients. So it is hypothesized that had the population been restricted to those patients, we probably would have reached significance. It is a unique therapy. Responses were actually seen in both the injected and uninjected lesions, showing a systemic immune activation, and the adverse effects were very manageable, with the majority being chills, pyrexia, injection site reactions, nausea, flu-like illness, and fatigue. Because of the type of agent that T-VEC is, there are some specific patient recommendations. So in general, the highest risk of viral transmission is with direct contact of the injection site or the dressing. And so it is recommended to avoid direct contact with these treatment sites, dressings, or body fluids, that gloves should be worn when changing dressings, and keeping these treatment sites covered for at least 1 week following treatment is also recommended. Additionally, all used dressings and cleaning materials should be disposed in a sealed plastic bag before throwing away. And finally, pregnant women should avoid exposure to all of these dressings and bodily fluid as well. So now that we've talked about immunotherapy in the adjuvant setting, we'll move into BRAF positive melanoma. So BRAF mutations are found in about 40 to 50% of cutaneous melanoma patients. And the majority of these are the BRAF V600E mutation, which is where at the BRAF 600 location, that a valine is what should be there, and instead we have a change over to a glutamic acid. About 5 to 12% of patients have the much less common V600K, and these are typically older patients. What these the BRAF activating mutations result in is enhanced signaling through the MAPK pathway, so the RAS, RAF, MEK, ERK pathway. And this is why we use BRAF inhibitors and MEK inhibitors to treat patients with BRAF positive melanoma. And again, I've gone through the previous, or the available BRAF inhibitors as well as the MEK inhibitors previously. So currently, Dabrafenib and Trametinib are the only BRAF and MEK inhibitors that are approved in the adjuvant setting, and this was based on a trial of 870 patients with completely resected stage 3 melanoma who harbored either a BRAF V600E or V600K mutation. The primary endpoint was 5-year relapse-free survival, and compared with placebo, the combination of Dabrafenib and Trametinib had a higher relapse-free survival rate of 52% compared with 36%. The adverse effects we'll talk about a little bit later in this presentation, but they were most commonly pyrexia, fatigue, and nausea. So this brings us to our next patient case. So we have HB, who is a 57-year-old man with recently diagnosed stage 3C BRAF wild-type melanoma involving his scalp. He underwent a wide excision with negative margins, and his treatment plan is for adjuvant Pembrolizumab. We're asked to provide patient education to HB prior to starting therapy. So which of the following immune-related toxicities is most likely to occur during the first 4 weeks of treatment with Pembrolizumab? A skin rash, hypothyroidism, flu-like symptoms, or elevated liver enzymes? So the most common toxicity that's seen in the first 4 weeks with single-agent Pembrolizumab is skin rash. We do see hypothyroidism and elevated liver enzymes typically later after a patient has started therapy, and we'll talk about that. And then flu-like symptoms are actually very uncommon with these agents. So we'll now move into talking about how we manage metastatic disease in terms of systemic therapy. This slide shows the first-line systemic therapy options for metastatic or unresectable cutaneous melanoma. You can see we have the single-agent Nivolumab or Pembrolizumab as Category 1 options, and we also have the combination of Nivolumab and Ipilimumab, which is also a Category 1 option. This combination was shown to have increased efficacy, but it does come at the cost of increased toxicity, and we will talk about in a few slides who this combination may be preferred in. All 3 of these are Category 1 options, however. For patients who have BRAF V600 activating mutations, the combinations of the BRAF and the MEK inhibitors are listed here and are all Category 1 options. There is no clinical trial to date that compares one of these combination therapies with another, and so they remain all options and can be selected based on patient preferences and side effect profiles. A new option that we have is the addition of the PD-L1 inhibitor atezolizumab to the combination of Vemurafenib and Cobimetinib. And this was a randomized double-blind placebo-controlled trial that did show longer median progression-free survival with this triplet combination. However, it did come at the cost of increased toxicity, and we're currently limited without having mature overall survival data, which is why it's a Category 2A recommendation. So whether this combination of all 3 agents is going to be superior to the sequential use of a BRAF MEK inhibitor and followed by a immune checkpoint inhibitor remains to be determined. An additional note, for patients with BRAF V600 activating mutations, they can receive either the immune checkpoint inhibitor options or the BRAF targeted options. Both are equal treatment options. However, if you have a patient who has more symptomatic, highly progressive disease, who has a BRAF mutated tumor, then it is preferred by the guidelines to utilize a BRAF MEK targeted option first, followed by the immune checkpoint inhibitors. So we just talked about the first line options. So what happens when your patient progresses? So this slide and the subsequent slide show the second or subsequent systemic therapy options for our patients. And you can see the list is very similar to what we saw on the previous page of the single agent Pembrolizumab or Nivolumab options, the combination option of Nivolumab plus Ipilimumab, as well as the BRAF MEK options. So for patients who have experienced progression during or shortly after their first-line therapy, it is recommended to consider second-line agents that were not used in the first-line setting or from a different class. So for example, if you do have a BRAF positive patient who got a single-agent Pembrolizumab first, then utilizing a BRAF MEK combination would be preferred and vice versa. For patients who progressed on single-agent anti-PD-1 checkpoint inhibitor therapy, so they got a single-agent pembrolizumab or nivolumab, the combination of nivolumab and ipilimumab, or even ipilimumab monotherapy, are reasonable treatment options to consider. For patients who experienced disease control, so they had a complete response, partial response, or even stable disease and had no residual toxicity from their first-line regimen, but then they experienced disease progression or relapse greater than 3 months after they discontinued that first regimen, you can utilize that first-line regimen or the same class of agents again. One addition to this slide is that the current guidelines were updated after these slides were finalized. Everything is always evolving, so it's always good to take a look at the most updated guidelines. We now do have the addition of the option of pembrolizumab with low-dose ipilimumab for tumors that have progressed after prior PD-1 therapy. So this is an additional preferred option. One additional note that I will add is that PD-L1 testing, which is something we'll talk about in a lot of other cancer types, is not currently recommended to guide immune checkpoint inhibitor therapy in melanoma. It is still considered investigational. It is being looked at as a predictive biomarker, especially in the single agent versus doublet nivolumab ipilimumab studies, but currently it is not a biomarker that we utilize regularly in the melanoma population to guide therapy. So this slide also lists some additional less preferred options that include single-agent ipilimumab. High-dose interleukin can still be considered for select patients with a really good performance status, normal organ function. It actually has a 2B recommendation for patients with small brain metastases. And then we also have some therapies that are useful in unique circumstances. The combination of ipilimumab and T-VEC actually showed a higher response rate than ipilimumab alone, but no increase in progression-free survival. And there was a shorter follow-up. So this is why it's a category 2B recommendation. For patients that have KIT activating mutations, imatinib can be considered. For patients with NRAS mutated tumors who have progressed on a prior immune checkpoint inhibitor, binimetinib, the MEK inhibitor alone, can be considered. And so this was based on rather marginal data showing a 15% response rate and no increase in overall survival compared to dacarbazine, and this is reflected in the category 2B recommendation. And then for our patients that have NTRK gene fusions, Laherparepvec or entrectinib is a treatment option. And then finally, our cytotoxic agents that are listed here are much more in the salvage setting. However, clinical trials would obviously be preferred. So moving on to our next patient case, we have a 45-year-old woman with newly diagnosed cutaneous melanoma of her left calf. Imaging shows 2 suspicious lesions in her liver, and an ultrasound-guided biopsy confirms metastatic melanoma, and genetic testing confirms the presence of the BRAF V600E activating mutation. She's currently asymptomatic and wishes to be aggressive with treatment, so she is started on the combination of ipilimumab and nivolumab. After 2 doses of this combination, she develops grade 3 diarrhea. What is the most appropriate therapy to manage her? Would we use high-dose loperamide, octreotide, methylprednisolone, or infliximab? So the most appropriate option is the steroid option, methylprednisolone. As we're going to talk about, the majority of treatment or of toxicities from our immune checkpoint inhibitors are going to be managed with steroids. There are some exceptions. Loperamide and octreotide are not recommended, and infliximab is utilized in the event that steroids are not effective. So now we'll delve a little bit deeper into the PD-1 inhibitors and their use in the metastatic setting, as well as discuss the management of their toxicities. So our 3 preferred first-line therapy options for metastatic melanoma are single-agent pembrolizumab, single-agent nivolumab, and the combination of nivolumab and ipilimumab. So the first drug that we'll talk about is pembrolizumab. So pembrolizumab was compared with ipilimumab in about 834 patients with unresectable stage 3 or 4 melanoma, and they were randomized to one of 2 doses of pembrolizumab or ipilimumab. And it is notable that the doses of pembrolizumab that were used in this study probably look even funnier now, that we've evolved to the initial approved dose of 2 milligrams per kilogram every 3 weeks, and now we have the flat dosing of either 200 milligrams every 3 weeks or 400 milligrams every 6 weeks, and those are typically the doses that you're going to see in practice now. So the 5-year follow-up median overall survival was released in 2019, and it showed that pembrolizumab had a 32.7-month median overall survival compared with ipilimumab at 15.9 months, and this was statistically significant. And the most important takeaway from this was that the responses are durable. That's the reason why we're still talking about this data, is that even after 5 years, patients who had a response stayed in a response. The optimal duration of therapy in the metastatic setting is unknown, though most patients who achieved a complete response or partial response and discontinued therapy at after 2 years of that therapy did stay in response. And so we still don't know the optimal duration of therapy, but data like this do give us confidence that stopping therapy after patients do achieve a complete response or partial response can be done. For this trial, the estimated 24-month progression-free survival in patients with a complete response was 85.4% and very similar at 82.3% in patients who achieved a partial response. So if you have a response, the chance of staying in that response is very good. So now looking at nivolumab, nivolumab alone was compared with ipilimumab alone or in combination. And I will call your attention to the combination that they utilized for this study, as it is the FDA-approved combination currently for melanoma, though there are other combination dosing regimens using nivolumab 3 milligrams per kilogram and ipilimumab 1 milligram per kilogram. That's actually used in the renal cell population, but there are some instances where it can be utilized in the melanoma population, and it has been investigated in the melanoma population. But the FDA-approved dosing is the one that is listed here. And so we now also have 5-year follow-up data for this trial as well. And the 5-year median overall survival for nivolumab alone was 36.9 months. For ipilimumab was 19.9 months, so a little bit higher, but very similar to what we saw in the pembrolizumab study. And most notably, the combination therapy of nivolumab and ipilimumab still has not reached the 5-year median overall survival, so ongoing at more than 60 months. So this is really encouraging for that group of patients. And also we know that the overall survival and progression-free survival in patients who discontinued ipilimumab and nivolumab due to treatment-related toxicity was similar to patients who did not discontinue due to toxicity. So if you have treatment-related effects and you do have to stop therapy, it does not appear to impede the responses that patients are seeing. And I will also note that nivolumab, again, it was dosed on the 3 milligram per kilogram dosing here. The 240 milligram flat dose every 2 weeks or the 480 milligram dose every 4 weeks are also the approved doses now. So we know that patients who receive the combination of nivolumab and ipilimumab together have a longer overall survival compared with patients who receive the agents individually, but this does come at the cost of a higher toxicity profile. And we're going to talk about this a little bit more as we delve into toxicity management. But what you can see here is that for single agent nivolumab, about 10% of patients had a grade 3 or higher toxicity. In the patients who received the combination, that went up to about 55%. So patients do need to consider that with this hope for higher efficacy, that they do have to accept the higher risk of toxicity. And so patients who have comorbidities or autoimmune disease are probably not the patients that you may want to be considering for the combination therapy. Of note, the combination of nivolumab and ipilimumab may be preferred in patients who have intracranial disease, however. So our take-home messages from this phase 3 trial are that the combination of nivolumab and ipilimumab did result in a higher median progression-free survival compared with either agent alone. However, it was accompanied by an increase in all grade and grade 3 or 4 toxicities. We're hopeful that biomarkers or other patient factors may be helpful to direct who should get this combination therapy. In the original study, it was shown that patients who had PD-L1 expressing tumors who were treated with nivolumab alone had a similar median progression-free survival. So patients with a PD-L1 negative tumor derive greater benefits from combination therapy. Patients who had a PD-L1 positive tumor had a similar median progression-free survival if they got single-agent nivolumab compared with the combination. However, as I said before, PD-L1 IHC testing is not currently utilized as part of standard care for melanoma in utilizing these agents, though optimizing this biomarker for selection of agents is something that is currently being investigated in clinical trials. So moving now to our fourth audience response question, we go back to AC, who has started her combined immunotherapy with ipilimumab and nivolumab, and she's tolerating therapy well, but she is having increased low-grade fatigue. So her medical team orders a TSH level as part of routine monitoring, and it comes back at 12. So how should she be managed at this point? Should we continue therapy and just continue to monitor the TSH and T4? Should we hold the nivolumab until the TSH normalizes? Should we start levothyroxine? Or should we continue nivolumab and start thyroid replacement therapy as well as prednisone? So our best option, since this patient has grade 2 toxicity with low symptoms, is to start levothyroxine. So if she had grade 1 asymptomatic disease, we could continue therapy and monitor. If she was extremely symptomatic, we would consider holding the drug, though we do want to correct the underlying hormonal problem. So we do want to start levothyroxine. The hormonal immune-related toxicities are the ones that we don't utilize steroids for as much as we do in the setting or for other toxicities. So what we ultimately want to do for the hormonal toxicities is to correct the underlying hormonal problem. And we're going to talk about this on subsequent slides. So we're now going to move into talking about the toxicities of our immune checkpoint inhibitors. And I absolutely love this graph. It's a great education tool for patients as you talk through everything so they can graphically see when we would expect these different toxicities to occur, as well as the severity that we may expect. So on the left, you see the toxicities associated with single-agent anti-PD-1 inhibitors, so your nivolumab and your pembrolizumab. And then on the right is the combination of nivolumab plus ipilimumab. So comparing the two right away, you can see the combination of adding in ipilimumab. We do see increased risk of toxicities, so increased incidence, increased severity, and they also occur earlier. Breaking down the different toxicities, you can first see the skin toxicities, and we're going to go through these most common ones in more depth in terms of their management in the upcoming slides. So skin toxicities are typically seen first within the first 2 or 3 weeks. Gastrointestinal toxicities, specifically diarrhea, and especially if you have ipilimumab involved colitis, can happen starting a little bit after about 5 weeks or so, but going from about 5 weeks to 8 weeks, and then tapering off. And then we have are more delayed toxicities like the liver toxicity and the endocrine toxicity that can happen after several cycles, more in the line of 6 weeks or later. Notably, the endocrine toxicities that you see here in green, it is the one line that levels out instead of going back down to zero, and that is because sometimes the endocrine toxicities can be permanent, where patients need to stay on a levothyroxine or even become diabetic and need insulin, and they don't always resolve. So that is an important educational point for patients. And then additionally, you have pneumonitis, you can see in the purple, that again can be a more delayed side effect and seen most commonly in patients who may have underlying lung disease, and we do see it more commonly in the non-small cell lung cancer population than we do in the melanoma population. Again, if you then contrast that with the combination therapy, again, each of those toxicities is represented. They occur earlier and they have an increased severity. So this is the reference that I would refer you to for the management of all things related to immune-related adverse effects from these checkpoint inhibitors. This is a joint guideline from ASCO and NCCN. It is more than 50 pages long, and it is a great reference for managing any body toxicity. They go into a lot of detail, and the information that I'm going to show you on the next slides are taken from this reference. So as part of this module, we will focus on the management of the most common immune-related adverse effects that we see with our immune checkpoint inhibitors. So by the nature of how the immune checkpoint inhibitors work, upregulating the immune system, sometimes the immune system gets confused and it can recognize other tissues and cause immune-related adverse effects. We will specifically talk about rash, colitis, pneumonitis, and primary hypothyroidism in terms of their management. However, these toxicities can occur in any system in the body. So in addition to the ones I just mentioned, remember that you can also have musculoskeletal, hepatic, renal, nervous system, hematologic, cardiovascular toxicities, and ocular toxicities. And again, I refer you back to the joint guidelines that break down each of these in terms of the populations you see them in, the frequencies you see them, as well as the management. So now we'll start discussing the management of the most common immune-related adverse effects. Each of these management guidelines are broken down by a different grade, so grade 1, grade 2, grade 3, or 4, and then the management recommendations on the right. For cutaneous toxicities, they most commonly manifest as a maculopapular rash, pruritus, and in the case if Ipilimumab is being included in the regimen, then vitiligo. They're typically lower grade, and so they're going to be managed with topical emollients or mild to moderate topical steroids, and then the recommendation to avoid irritants, but also sun exposure, which can exacerbate these toxicities. Once you get to a grade 2, that's where you can consider holding the immune checkpoint inhibitor, and it is recommended to hold the inhibitor for grade 3 and 4, and as well as consulting dermatology. And I think that that is an important point to bring out, that multidisciplinary management of each of these toxicities is really recommended to give the most benefit to patients. Grade 3 or greater toxicities are rare, but often do require systemic corticosteroids. So prednisone 1 milligram per kilogram can be considered with a grade 2, but methylprednisolone is recommended once you get to a grade 3 or grade 4. For gastrointestinal immune-related adverse effects, these can occur anywhere within the gastrointestinal tract, so including mucositis, colitis, enteritis. Colitis is actually most commonly seen with ipilimumab alone or with ipilimumab-containing regimens. It is important that a biopsy be done early to rule out colitis if a patient presents with diarrhea. And again, you can see broken down by grade 1, where we have a lower grade diarrhea, that's where you can continue the immune checkpoint inhibitor or hold based on the severity, but it is important to monitor the patient for dehydration. Once a patient actually has grade 2 diarrhea, that's where holding the immune checkpoint inhibitor until resolution is recommended. And if the patient is still receiving the CTLA-4 inhibitor Ipilimumab, then it is recommended to permanently discontinue that. Again, consulting with gastroenterology and making sure that imaging is being done is important. And this is where starting systemic steroids are recommended. We do have to be aware of absorption issues with colitis sometimes. And so if there is any indication that absorption may be a problem, especially when patients are having more severe diarrhea, then this is where consideration of IV steroids would be utilized. And this is also where you're going to start seeing Infliximab in addition to the steroids. For patients who have grade 4 life-threatening consequences, IV steroids are recommended in addition to Infliximab, especially if a patient is refractory after 2 to 3 days of steroids. Vedolizumab may also be considered in this case. So pneumonitis is also a very well-recognized immune-related adverse effect. We really started to see pneumonitis more as we moved away from single-agent Ipilimumab, where it was not seen very commonly, towards when we were utilizing the PD-1 inhibitors, especially when we started to utilize them in lung cancer patients. So it can really be challenging to diagnose in patients with lung cancer or chronic lung disease based on the radiographic imaging. And we can see that the grading ranges from asymptomatic, also considers how much of the lung lobe is involved. And again, we start with holding of the immune checkpoint inhibitor therapy if we have evidence of pneumonitis progression. It can be resumed with evidence of improvement, but patients should be monitored very closely. So as we get more symptomatic and more lung gets involved, this is where, again, we're going to be managing it with steroids. Empirical antibiotics can be considered. And then once we get to more severe symptoms, especially if a patient has the majority of their lungs involved, permanent discontinuation of therapy is recommended, as well as IV corticosteroids and additional agents like infliximab or mycophenolate mofettate or even cyclophosphamide. Steroid tapers should be done very slowly over about 4 or 6 weeks, and we're going to discuss some of the other considerations when we're doing a slow taper that we have to consider. Pulmonary should definitely be involved with these patients to optimize their outcomes. So this brings us to our endocrine toxicities and specifically highlighting hypothyroidism. So endocrine toxicities can actually present in a variety of different ways. They can be asymptomatic with just routine lab changes. This would be a grade 1 side effect here. Patients may present with fatigue, especially with hypothyroidism. Headaches, mild to severe, could be indicative of hypophysitis, which is most common with Ipilimumab-containing regimens. Polyuria or polydipsia can be seen if patients are developing diabetes. Shortness of breath, as well as palpitations. So the most common manifestations are either hypo or hyperthyroid. But patients can also have hypopituitarism, type 1 diabetes, as I mentioned, or hypophysitis, which is the inflammation of the pituitary gland. So again, unlike the side effects that we've talked about to date, what we want to do in these cases is really replace the hormone that's needed. Steroid therapy doesn't have a role except in very severe cases where patients have severe life-threatening symptoms. So if you have a patient with bradycardia or hyperthermia based on the endocrinopathy, then it can be considered. But in general, what you're going to be looking at is this, in this case for hypothyroidism, thyroid supplementation, and then monitoring patients and adjusting. And this is why it's important to involve your endocrinologist in the management. The last thing that's really important to emphasize with endocrine toxicities, and if you remember from the chart that I showed you earlier, these are the most common toxicities that may not always resolve with therapy. Once stopping the immune checkpoint inhibitor, patients can continue to require hormonal supplementation for their endocrine-related autoimmune or immune-related side effect. And so this is important to educate patients about this. So I think if you're taking the exam, management of immune therapy, immune-related adverse effects is a very, very likely question that you're probably going to see. So I would be comfortable with the most common ones that we've discussed here. And remembering that typically grade 1, you can often continue the immune therapy with close monitoring. There are some exceptions, some of which we've talked about, including, but also including the neurologic, the hematologic, and the cardiac toxicities. Grade 2 is where you're more likely going to have to hold the immune therapy and resume when it's resolved to grade 1. And this is where you're going to start to see oral steroids being utilized as we progress to grade 3 and grade 4. Again, continuing to hold therapy, and continuing to give steroids, possibly needing IV steroids. If there's no improvements after starting IV steroids, then considering Infliximab. One exception to that is in the case of a liver toxicity or hepatitis, then you would utilize mycophenolate instead. But in general, I would kind of look at the broad way of managing these and then looking at the ones that are different, like the endocrine toxicities that we just talked about. It's really important. Any of you who work with the immune checkpoint inhibitors know the importance of patient education and making sure that patients have a high level of suspicion for new side effects. We always used to say, if you have any changes in your bowel movements, it may seem insignificant, but just let us know so that we can start tracking this. And one last point, unlike how we manage a lot of different side effects for other therapies, dose adjustments are not recommended. If we restart the therapy following toxicity, you would restart at the full dose. You would not do a dose reduction. So, and our last point is considering that many of these patients may have to be on steroid tapers for 4 weeks or even 6 to 8 weeks, especially if they have pneumonitis or hepatitis. So, we do have to consider how we would manage these patients like we would a long-term steroid patient. Herpes zoster prophylaxis can be considered in general. For patients with a higher risk of gastritis, proton pump inhibitors or H2 blockers can be considered. And then for patients who are receiving prednisone at 20 milligrams daily for 4 weeks or more, they may require PJP prophylaxis. And for patients receiving prednisone 20 milligrams daily for 6 to 8 weeks or longer, they may require antifungal prophylaxis. Vitamin D and calcium is recommended to prevent osteoporosis. And then in terms of vaccination, inactivated or killed vaccines can be utilized during the immunotherapy period, but live vaccines should be avoided due to the lack of data currently. Now that we've focused on immune checkpoint inhibitors and managing those toxicities, let's finish up our systemic therapy discussion by talking about BRAF and MEK inhibitors. This brings us to our next question. So 8 months following the completion of combined immunotherapy, our patient AC develops progressive disease with an increase in symptoms due to tumor burden from her BRAF-positive metastatic melanoma. Which is the best subsequent treatment option for her at this time? T-VEC, Pembrolizumab, Vemurafenib, or the combination of Encorafenib and Binimetinib? So in this case, we would utilize the combination of Encorafenib and Binimetinib. Single-agent BRAF inhibitors are not typically recommended anymore unless patients are unable to tolerate the combined BRAF MEK therapy. The patient's already progressed through the combined immunotherapy, so Pembrolizumab would not be preferred, and the patient has metastatic disease with several sites of involvement, and so T-VEC would not be preferred either. So we've been talking about BRAF inhibitors throughout this discussion, but just a reminder that whenever we first started using BRAF inhibition, we utilized the drugs as a single agent. We soon found that resistance to single agent BRAF inhibition alone typically occurred after 6 to 7 months in most of our patients who were treated with a single agent BRAF inhibitor. So the combination of a BRAF and downstream MEK inhibitor was studied and found to be successful because it suppresses downstream resistance mechanisms. Therefore, combination therapy is the preferred recommended treatment for patients with BRAF V600E or V600K mutations. It is important to remember that immunotherapy still does remain an option for these patients. So AC is beginning treatment with Dabrafenib and Trametinib. After 3 weeks of therapy, she develops a persistent temperature of 39 degrees Celsius. How should this be managed? Should we continue her on therapy and start prednisone 10 milligrams daily? Should we hold both Dabrafenib and Trametinib until the fever has resolved and then restart at full dose? Should we hold just the Trametinib until the fever has resolved and then restart at full dose? Or should we hold therapy and start prednisone 20 milligrams daily? So our best option is going to be to hold the Dabrafenib and the Trametinib until the fever is resolved and then restart the full dose. So first we're going to hold treatment, and then if there is no resolution, then this is where adding in the steroid, typically prednisone 10 milligrams daily, could come into play. So just briefly to review, this was one of the trials that helped to show the benefit of combined therapy with Dabrafenib and Trametinib compared with single-agent Vemurafenib alone. We can see the combination had an improved progression-free survival and overall survival, both of which were statistically significant. I do want to take some time, though, to focus on the toxicities. So it is notable that typically whenever you combine drugs together, you have an increase in toxicities. It's interesting that while this was seen with pyrexia, pyrexia fever is seen any grade in about 53% of patients treated with Dabrafenib and Trametinib. This is typically defined as a temperature of at least 38.5 degrees Celsius, and it usually occurs about 2 to 4 weeks after the patient has started therapy, and can last about a median duration of 9 days. Again, we treat it first by interrupting and stopping therapy, and then resuming at full dose once the symptoms have resolved. If patients do not have a full resolution, then this is where the use of prednisone 10 milligrams per day can come into play. In addition to pyrexia, cutaneous side effects can also be seen. So hand-foot syndrome, hyperkeratosis, cutaneous squamous cell carcinomas have all been reported. However, utilizing the combination with the MEK inhibitor actually reduces the side effects, the cutaneous side effects that we're seeing with the single-agent BRAF inhibitor. Skin assessment is recommended regularly with these drugs. And these images just demonstrate what the BRAF inhibitor single-agent dermatologic effects can look like. This macropapular rash with these keratoacanthomas. You can see a close-up of one of these kind of benign lesions that is starting to develop potentially some malignant changes on it. And then also, unlike the EGFR drugs, the single-agent BRAF inhibitors actually do get these pustular whitehead reactions that we can treat as traditional acne. And I thank my patient who very willingly allowed me to share these slides. So in addition to Dabrafenib and Trametinib and Vemurafenib and Cobimetinib, the newest BRAF MEK inhibitor combination is Encorafenib and Binimetinib. And this was the clinical trial that led to the combination approval. So the combination of Encorafenib and Binimetinib was compared with Encorafenib alone and Vemurafenib alone. And one thing I will note about this is in this trial, the dose of the approved dose of Encorafenib that was utilized was 30 milligrams daily in combination with Binimetinib 45 milligrams twice a day. It was noted that the maximum tolerated dose of Encorafenib when given with Binimetinib was actually higher than Encorafenib alone, which ultimately allowed for the higher subsequent and approved dosing of 450 milligrams once daily. Not surprising, the combination of the BRAF plus MEK inhibitor was superior to either of the BRAF inhibitors alone with a median progression-free survival of 14.9 months and median overall survival of 33.6 months. Each of the BRAF MEK inhibitor combinations do have some slightly different toxicities. Encorafenib and Binimetinib is associated with an increase in gamma glutamyltransferase increases and creatinine phosphokinase increase, as well as hypertension. So Encorafenib Binimetinib does represent an additional BRAF MEK combination for patients with BRAF V600 mutated advanced melanoma. It does have a slightly different side effect profile. There are lower rates of pyrexia and photosensitivity, and there are also planned future trials in combination and sequential therapy with immunotherapy. So we've talked about the immune checkpoint inhibitors that have really revolutionized the way that we treat melanoma. We've talked about the BRAF MEK inhibitors for patients with BRAF mutated melanoma, and I do want to throw in just one final slide on the oldie but goodie interleukin-2. So the specifics of interleukin-2 are going to be covered more in the renal cell module. However, it is still a recognized treatment option because just like these other immune therapies, though response rates are lower at 15 to 25%, there are a small number of patients that actually do have a durable response. It was actually the first immune therapy that started to give us the clue that immunotherapy could be really useful in melanoma. Its high rate of grade 3 and 4 toxicities really do limit its regular use, though, including that toxic death rate of 2.2%. So it is really only to be considered in patients who have a good organ reserve, good performance status, and being given at a site that is experienced with its use. I'm going to leave you with this last summary slide of the agents that we've talked about and their places in therapy. I want to thank everyone for their participation, and I also want to thank my patients for whom I am so blessed to have been a part of being able to take care of them and who have taught me about how to manage the side effects I discussed today.